Assalamu alaikum and a very warm welcome to all the participants joining us from across Pakistan and beyond. It is my privilege to moderate today's academic session organized by the Pakistan Endocrine Society on the topic Perioperative Management of Pituitary Adenomas. As pituitary adenomas present a unique clinical challenge requiring the coordinated expertise of endocrinologists, neurosurgeons, radiologists, and anesthetists. This session aims to highlight the critical role of the endocrinologist in the intra, and post-operative care of patients undergoing surgery for pituitary tumors. And as we are now in the dissemination phase of our pituitary adenoma guidelines, which are being launched by Pakistan Endocrine Society, this is the series of those lectures. So we are honored to have with us today Dr. Shahid Ahmed, who is a distinguished endocrinologist from Hearts International Hospital and executive member of Pakistan Endocrine Society. And so Dr. Shahid will walk us through the clinical approach, pre-surgical optimization, hormonal management protocols, and various management strategies and key red flags to watch out for in the post-op phase. We are equally grateful. I would like to invite Dr. Shahid. As Dr. Shahid has already joined us, now we are equally fortunate to be joined by two esteemed experts who will share their valuable insights during the panel of discussion. So we have with us Dr. Aisha Sheikh, who is an accomplished endocrinologist and currently she's heading as president of Pakistan Endocrine Society. So I welcome to Dr. Aisha Sheikh. And our next panel of experts is Professor Najmul Islam, who is a renowned endocrinologist, academician, and a leader in the field of pituitary medicine. We welcome you, sir, on the board. So,
thank you.
So I welcome to all our distinguished panel of experts and our speaker. And as all of them have joined, we will now start with the presentation. So over to you, Dr. Shahid.
अस्सलाम वालेकुम।
वालेकुम अस्सलाम।
सर क्या हाल हैं?
ठीक।
डॉक्टर साहब शुरू करूं मैं?
जी सर, प्लीज स्टार्ट विद द प्रेजेंटेशन।
वो एमसीक्यूज का तो वो रह गया, वो मैं फिर बाद में दिखा दूंगा इसके बाद।
सर आफ्टर प्रेजेंटेशन यू कैन डिस्कस द
जी ठीक। Assalamu alaikum. Today we are presenting our section of perioperative endocrine management of pituitary adenomas in pituitary adenomas guidelines. Transsphenoidal surgery for pituitary adenomas require careful perioperative care due to the delicate nature of pituitary function and the risks of complications. All patients with pituitary adenomas need a thorough endocrine evaluation in the preoperative period and postoperative period, especially in view of the need for hormone replacement therapy. Serum prolactin and IGF-1 should be measured in all cases of pituitary adenoma. Patients with pituitary macroadenoma should undergo evaluation for secondary adrenal insufficiency. Patients with pituitary tumor who present with manifestations of adrenal insufficiency should be evaluated for adrenal reserve, regardless of the size of the lesion. All patients with pituitary adenoma who show any symptoms or signs of cortisol excess should be evaluated for Cushing's syndrome preoperatively. Thyroid functions should be tested in all patients with pituitary tumor. Gonadal functions should be assessed in those patients who present with symptoms of hypogonadism, who have large pituitary mass, or who have a functioning pituitary tumor regardless of the size. Patients with pituitary mass should be evaluated for diabetes insipidus if they have polyuria or hypernatremia. Patients with secondary adrenal insufficiency should be replaced with glucocorticoid, and patients with secondary hypothyroidism should be optimized with thyroxine replacement preoperatively. Perioperative stress dose glucocorticoid administration is recommended in all patients with known or suspected adrenal insufficiency. Stress dose glucocorticoid is hydrocortisone 100 milligram IV bolus followed by continuous IV infusion of 200 milligram hydrocortisone per 24 hour, or alternatively 50 milligram can be given every 6 hours. In patients with acromegaly, preoperative medical management with somatostatin receptor ligands, and in patients with Cushing's disease, preoperative medical management with mitairapon or ketoconazole can be considered to reduce the hormone burden in selected patients. In postoperatively, serum sodium levels should be monitored for approximately 7 to 10 days. Symptomatic hyponatremia may occur in up to 5% of cases. Transient and permanent DI can occur in up to 4.3% and 0.3% cases, respectively. Central diabetes insipidus can cause hypernatremia. Hyponatremia may be due to syndrome of inappropriate ADH secretion, SIADH, cerebral salt wasting, or hypocortisolism. In the post-operative periods, patients who did not have secondary AI preoperatively, serum cortisol should be measured at 8 to 9 a.m. on day 1 to 5 after surgery. A cortisol level less than 3 microgram per deciliter is indicative of adrenal insufficiency, and a cortisol level greater than 15 microgram per deciliter excludes an adrenal insufficiency diagnosis. In those cases who have in-between values, dynamic testing to assess hypothalamo pituitary adrenal axis should be done at 6 to 12 weeks after surgery if morning serum cortisol was insufficient in the early postoperative period, as I said already. Biochemical testing for HPA axis is done at least 18 to 24 hours after the last hydrocortisone dose, or longer for synthetic glucocorticoids. Complete pituitary hormonal profile should be done at 6 to 12 weeks postoperatively. In patients who are operated for prolactin-secreting tumor, serum prolactin may be measured postoperatively on day 1 or 2 to evaluate for remission. Thyroid functions should be assessed in all patients at 6 to 8 weeks after pituitary surgery. A free T4 below the reference range in association with a low, normal, or mildly elevated TSH usually confirms a secondary hypothyroidism diagnosis. Gonadal functions should be evaluated at 6 to 12 weeks postoperatively in men and premenopausal women. In patients with acromegaly, morning serum growth hormone may be measured on day 1 or 2 after surgery to assess remission. And serum IGF-1 should be checked at 6 weeks postoperatively to see endocrine remission. If it remains elevated, it should be re-evaluated at 12 weeks to make a decision about persistent disease. A glucose tolerance test for growth hormone suppression may be carried out to confirm endocrine remission in acromegaly after several weeks of surgery. In patients with Cushing's disease, post-surgery morning serum cortisol is used to assess remission after surgery. It is usually performed 1 to 7 days after surgery before morning glucocorticoid administration. And remission is very likely for values less than 1.8 microgram per deciliter. remission is likely for values less than 5 microgram per deciliter, and persistent disease is almost there for values greater than 7.2 microgram per deciliter. 24-hour urines, 24 hours urine for free cortisol measurement may be used to assess biochemical remission. And similarly, late night salivary cortisol measurement can also be used to assess remission, as we do in diagnosis of Cushing's disease. While managing post-operative DI, desmopressin may be used as required in the post-operative period if the patient develops cranial diabetes after pituitary surgery. In post-pituitary surgery DI, the clinicians should make at least one attempt to discontinue DDAVP during the weeks or months after surgery to determine whether posterior pituitary function has recovered or not. In cases of adipsic DI, which occurs due to hypothalamic damage, DDAVP and fluid intake titration should be done carefully by frequent weighing and serum sodium level monitoring. Euvolemic hyponatremia may result from SIADH, while hypovolemic hyponatremia is caused by cerebral salt wasting. The management of SIADH after pituitary surgery constitutes a period of careful observation followed by free water restriction if the hyponatremia persists. Hypertonic saline administration or treatment with vasopressin 2 receptor antagonists may be considered in refractory cases. Cerebral salt wasting is managed by fluid repletion with normal saline and oral salt replacement. In refractory cases, fludrocortisone may be used with monitoring for hypokalemia, fluid overload, and hypertension. In conclusion, patients requiring pituitary surgery, it is required that we have a multidisciplinary perioperative approach to avoid complications. And careful optimization of perioperative endocrine care may have a significant impact on quality of life and long-term survival of the patients. Thank you. Any questions?
Thank you so much, Dr. Shahid, for that comprehensive and clinically relevant presentation. So moving on, we have can open the floor for questions. If there are any queries, the attendees can post their questions in the chat box in the question and answer session. And if there's no question from the session, then Dr. Shahid, you can discuss your questions.
Should I present the MCQs?
I have the MCQs. I'm posting them over here one by one.
Okay, okay.
People can answer them, and then you can share your presentation with the answers so that they can know the right thing.
Okay.
So we encourage our all attendees participate actively and make this session interactive and enriching. So here's a poll for you.
Should I read the question?
Yes, sir, sure.
A 35-year-old woman suffering from acromegaly underwent transsphenoidal surgery for pituitary macroadenoma. To confirm endocrine remission of acromegaly, IGF-1 should be measured on 2 days after surgery, 2 weeks after surgery, 4 weeks after surgery, 6 weeks after surgery.
And Dr. Hyde, after your talk, there should be easy to attempt these questions. So we should be expecting 100% performance from our attendees.
Actually, हमने ये देखना था कि ये प्रेजेंटेशन से पहले कितने लोग करेक्ट करते हैं और बाद में कितने?
हाँ, अब तो 100% होना चाहिए करेक्ट।
जी सर।
Do we have
48
results?
years. Should I read the next question?
Yes, sir, please.
A
Carry on.
48 years old man has developed polyuria a day after pituitary surgery for non-functional pituitary tumor. His blood pressure is 100/60, pulse 108 beats per minute, temperature 97.8, and respiratory rate 18 per minute. He is clinically dehydrated and systemic examination is unremarkable. Serum sodium is 126 millimole per liter, potassium 4 millimole per liter, and creatinine 1.3 milligram per deciliter. Probable cause of this post-operative hyponatremia is SIADH, diabetes insipidus, hypocortisolism, or cerebral salt wasting. Question number 3. In a 52 years old woman, transfemoral surgery was carried out for a non-functional pituitary tumor with no pituitary hormone deficiency preoperatively. On third post-op day, 9 a.m. serum cortisol was done to evaluate adrenal function. Which 9 a.m. serum cortisol value is the minimum level to exclude adrenal insufficiency? Last question. A 36 years old lady with Cushing's disease due to pituitary adenoma underwent transsphenoidal surgery. 2 days after surgery, serum cortisol was sent at 8:30 a.m. before morning dose of glucocorticoid. Remission is likely at a cortisol level of less than 5 microgram per deciliter, less than 10 microgram per deciliter, less than 15 microgram per deciliter, and less than 20 microgram per deciliter.
Shall I share the results now for each question, one after the other?
Yes. Very good. 55% have correct answer.
हाँ लेकिन I mean I'm a bit disappointed कि 55 नहीं होना चाहिए.
But I'm happy that majority
चले, it's a different
have
way of
answered.
doing things.
Yeah. Yes. Sir. Next. Again, 58% have the correct answer. Good. This was hypovolemic hyponatremia. So it's cerebral salt wasting is good. Next.
हाँ लेकिन ये जरा सा ये था कि भाई डायबिटीज इंसिपिडस कैसे आ गया है, लिख कैसे दिया
जी
है
सर. सर हाँ, ये जिन्होंने 25% नहीं किया है ना सर, वो पॉलीयूरिया की वजह से सर लोग डिसीव होते हैं.
हाँ लेकिन सोडियम लो हो रहा है तो ये
हाँ जी सर, सोडियम लो होना से. जी सर, ये 25% नहीं आना चाहिए था डायबिटीज इंसिपिडस. तो 73% have answered correctly.
This is good.
This is good, sir. %60.
ये कि लास्ट वाला तो नहीं आ रहा, पता नहीं आया आपके पास लास्ट का.
ये आ गया सर. Less than 60% ने करेक्ट किया सर.
लास्ट क्वेश्चन कौन सा था, वो कोर्टिसोल वाला?
जी सर, वो कुशिंग्स डिजीज रेमिशन.
ओके ओके ओके, ठीक है. I think Dr. Vaswa should now proceed with the program. क्या ताकि
Yes, sir. So we will now proceed with the question and answer from the audience. So as we see from the results that almost 50 to 60% of our audience have gained some benefit and control from this topic. So still, I think there is a room for questions. So anything, if there is some ambiguity about any protocol or hormone testing, they may ask in the chat box or in the question and answer chat box.
So till our audience sends their questions, can I ask the question from you, Dr. Shahid?
Yes.
So I think the in the post-operative period, the fact that there is a problem with the sodium and water balance in the post-operative period, and this was very highlighted very well by you. Conditions like diabetes insipidus, hyponatremia, SIADH, and cerebral salt wasting can occur. So how often they should be testing their sodium levels? And suppose if a patient is having diabetes insipidus, how often they should be giving desmopressin, because there would be a risk that the patient would go into a triple phase, DI and then SIADH can occur as well. So what is your advice to our audience?
Yes. Due to the occurrence of transient DI and alternating DI and SIADH and again DI, which were triphase, we have to be very careful. That is why we have to monitor sodium daily or twice daily for at least 7 days after surgery. And DDVAP, AVP is given, desmopressin is given very carefully as required basis, while carefully monitoring for the urine output and sodium levels. So it has to be a careful, it's all observation. basically.
Thank you. So you mean to say that desmopressin should be given as stat doses and should not be written in the medical record, like, because we cannot risk having additional desmopressin when the patient was not needing it.
Yeah. Oh, if it is given as a nocturnal tablet, usually we give in the form of tablets due to nasal surgery. So if it is given single nocturnal dose, that can be given daily for 2-3 days. We usually do not give a permanent twice daily dose in these patients. So we give a nocturnal tablet for 2-3 days and keep on monitoring and
The
stop the
sodium level
tablet or
and-
increase
yeah.
the tablet as required.
So one situation would be that if the patient is alert and is able to drink and has a normal
Yes.
thirst reflex, they will be having their oral water intake as well. But in situation like you mentioned about adipsic DI, what should
Yes.
be the ideal management in those situations? Because that is a very tricky situation, especially if the patient becomes permanent DI and is having adipsia as well.
Yes.
How should they be managed on a long-term outpatient basis? How will be monitoring? How will be managing? What advice should be given to the patient at the
In
time?
those patients, frequent sodium level monitoring is required, depending upon the patient, because urine output, clinical hydration status, any signs of fluid overload, then regular sodium monitoring, all these are essential. It's a very difficult patient. An unconscious patient with DI or an adipsic patient with DI, it's a difficult situation to manage. And it's all I already said. It's observation of the hydration status, blood pressure, and fluid overload, and sodium levels.
Thank you, Dr. Thank you very much. Do we have any questions?
We don't have any question from the audience yet, but I received a message that chat is disabled. So if the admin can just check if this.
They can write the question and answer box. There's the question and answer box on their.
Yeah, in the question and answer box, I have
Yes.
replied that they may type question here. So,
Okay.
yes.
I thought that till our audience asks questions, we can have a discussion amongst ourselves.
Yeah.
So, do you have a question, Dr. Mustafa or Dr. Shahid?
I have a question that according to the PES guideline recommendation about tapering of the steroids in the post-op period and then reassessment of the hypothalamic pituitary axis. So what is your take on that?
For cortisol measurement in the immediate post-operative period, only morning dose of hydrocortisone should not be given. Whether we want to do a single cortisol level or we want to do a hydrocortisone day curve. For dynamic testing, which we usually do after 6 weeks, for dynamic testing, 18 to 24 hours previously, 18 hours previously hydrocortisone should be stopped. And if we are using these synthetic glucocorticoids, that we may have to stop for a longer period, then we can do the dynamic testing. But for single cortisol measurement in the immediate post-operative period, only omitting morning glucocorticoid dose is enough before testing.
Dr. Shahid, I may ask one thing that I've seen that quite a few neurosurgeons give dexamethasone to the patients in the perioperative period for non-functioning pituitary adenomas I'm talking about. So
Yes,
in
sir.
that sort of a patient, obviously cortisol measurement
It's
has
very
to be-
difficult, sir.
Yeah, so that is something that
Yes.
I would like you to answer.
Yes, sir. So they should not give dexamethasone unless there is a clinical indication of severe cerebral edema or anything like that. Perioperatively, hydrocortisone should be given. Otherwise, hormone cortisol assessment is very difficult.
Well, I think
We'll
that
have
is
to.
recommendation, but sometimes the neurosurgeons, yes, that is important.
Then we have to taper off this dexamethasone and then reevaluate the patient, which we usually do as in our clinical practice. We stop dexamethasone or taper off dexamethasone and wait for a while and then reassess the patient.
It's a long-acting drug, so at least 48
Yes.
hours to band karne ke baad you have to.
Ji, sir.
Cortisol to see whether the body is producing or not.
Yes, sir.
Thank you so much. I have a question, sir, that the perioperative steroid, the stress dosing, should all patients receive, or only those with documented ACTH deficiency should receive this in the
not all
adenoma
patients.
management?
Patients who have confirmed adrenal insufficiency preoperatively or suspected to have adrenal insufficiency, they should
Because
be given.
many times we see that there is no indication, but we may see that perioperatively they've been given in the absence of any documented.
That is why these guidelines are produced.
Yes, exactly. So I think with the discussion, this makes it more clear.
Yes.
Okay, so
Dr. Shahid, but I understand that if we have checked their cortisol levels in the pre-op period, and that was normal, then that patient might not need a perioperative cover. But if it wasn't checked for one reason or the other, then to be on the safe side, should that?
Yes, it should be given,
covered?
because that if it is not checked, then it is a suspected case.
Okay. The
Yes.
other thing is that suppose that the level was checked, but during surgery, the surgeon found that this was a difficult tumor and that was a difficult surgery. And they might suspect that there could be a damage to the corticotropes. Then that will become an additional indication that they can give
Yes.
cooperative glucocorticoid coverage for such.
Yes. When there is a doubt, you can also give perioperative cover or give post-operative support also, and we can assess that patient later on.
Yes. So whenever in doubt, it's better to give steroid
Yes.
coverage rather than avoiding
Yes.
it. Because
Whenever in
that
doubt, it is a
is-
suspected case. Then
Yes.
you should act on your clinical indication.
And
Okay, so
hydrocortisone is preferred over other
Other
steroids.
Yes, synthetic glucocorticoids, definitely, because of the ease of assessment. With synthetic glucocorticoids.
And the shorter duration of action.
Yes, sir. Duration effect also, sir.
we have a question from the audience that in a hypopituitarism patient after surgery, if having secondary adrenal insufficiency, then how to assess diabetes insipidus, as there is deficiency of cortisol, which may mask diabetes insipidus. So how to approach such patient?
Yes.
So it's
It's
a
a very good question.
from-
This is a very good question. It usually masks and mild DI may absolutely disappear when there is hypocortisolism. In such patients, whenever we replace with hydrocortisone, they start having polyuria, and then we should suspect that he is having diabetes insipidus, and then we assess diabetes insipidus as we do in regular practice with osmolalities and sodium level, and if we water deprivation test if it is required. So whenever a patient who is replaced with hydrocortisone due to hypopituitarism develops polyuria after ruling out diabetes, we should suspect that he has a hidden DI or masked DI, which has unmasked now. And this we see in clinical practice.
Thank you so much, Dr. Shahid. I hope this clears this query. And we don't have any further question as yet. So I will, I think.
I have a question, Dr. Rasta.
Okay.
So Dr. Shahid, suppose a patient with Cushing syndrome and post-operative during within a week after surgery, the patient was found to be in remission less than 2 cortisol level, and then you will decide that you will continue that patient on hydrocortisone replacement doses. At what interval you will be aiming to reassess the hypothalamic pituitary adrenal axis to look for recovery of the axis that might occur over a period of time? So after what interval ideally should that be tested for the first time?
This recovery depends upon in different patients at different times. But we should at least start testing after 6 weeks. And further testing depends upon the patient. Because in some patients it recovers early, in some patients very late, and in patients who have, in some patients would have developed permanent hypopituitarism. They would not. So we should start reassessing 6 weeks. I don't remember what is written in Cushing syndrome guidelines actually, but usually this is a practice we start after 6 weeks.
Achha, Dr. Shahid, I just wanted a clarification for
आवाज सर की गायब।
अगर किसी को कुशिंग्स डिजीज की सर्जरी हुई है एंड
जी सर
48 आवर्स, आवाज आ रही मेरी?
अब आई सर, कट रही है बीच में। जी सर।
अच्छा, हो सकता है नेट का कोई इशू हो। एनीवे मेरा कहना था कि कुशिंग्स डिजीज की सर्जरी हुई और सर्जरी के बाद आपने 48 आवर्स के बाद 8 AM कॉर्टिसोल किया, जो कि आया समथिंग ऑफ अ बॉर्डर लाइन व्हिच इज 5 या 6।
यस सर।
तो इस तरह के पेशेंट्स में obviously there is a possibility that the patient may have been cured or may not have been cured, इस तरह के 5 levels पे। In these patients, do you recommend that they should be on steroid replacement, or should they be followed up further with further levels, and then a decision should be made about hydrocortisone to be given or not to be given?
So these borderline cases, they should be replaced with hydrocortisone, and after 6 weeks they should be reassessed with dynamic testing, because they may be deficient, and which deficiency will be unmasked during stressful situation.
The other thing for such borderline cases would be that these patients who are actually having Cushing's disease were used to very high cortisol levels in their systems, and they will be having steroid withdrawal symptoms if we do not replace even these borderline cases.
Yes.
That would be another reason that we
Yeah.
will need to replace them in a few weeks early post-operative period, and then, as you suggested, reassess them 6 weeks later for whether there's recovery of HP axis or not.
Yes, definitely.
So I think most of the key points and key messages, questions have been discussed. So we will now move into the expert panel discussion. And I would like to invite Professor Najmul Islam and Dr. Aisha Sheikh to share their reflections on the talk and further expand on key clinical dilemmas we often face in managing pituitary tumors around the surgical window. Over to you, Dr. Aisha.
Professor Najam, take the comments from Professor Najam first.
I mean, obviously, Dr. Shahid has covered this topic nicely and within a comprehensive way, and has shared different options of situations where we have to approach in different ways. We have also contributed in the discussions some clarification on this as well. But obviously, this is a very important topic that the trainees, endocrine trainees should know, and also the internal medicine trainees should know about how to manage these patients appropriately. And a lot of mistakes are made by them because of not knowing the subject very well. So it's an important topic, very important topic to be addressed. And we have done that today in the presentation by Dr. Shahid and in the discussion that we had subsequently. I specifically had some quick questions, which I've already asked Dr. Shahid So not much to add here. But again, Dr. Aisha may shed some lights more on this topic.
Thank you, Professor Najam. So I will go back to the time when we were developing these guidelines. It's been almost 3 years. Professor Dr. Shahid and Professor Najam can recall
Yes,
that
it's almost 3 years.
during pandemic we started working on this, and this was because Professor Athar Inam from Pakistan Society of Neuro-Oncology approached Pakistan Endocrine Society. Professor Khurshid Khan was the president at that time. And Dr. Professor Athar Inam requested that there should be a joint effort for countries like us, Pakistan, and thus the guideline is developed in a manner of a resource adapted approach for lower middle income countries. And all those authors who were the primary authors for each chapter are actually presenting in the webinars, and all these webinars are recorded and are available on Pakistan Endocrine Society's YouTube channel, which is by the name of PES TV, PES space TV. And also this is a repository for all of you, and you can go back to those sessions, listen to those. The guideline is published as a supplement from JPMA. So this is available on the website of JPMA, and you can go through the guidance again and again and look at how you can improve your patient care based upon these guidelines. So coming to today's session, which is very important when we talk, just a moment, I need to, just a moment. Yeah. Sorry for the disturbance. So, so this part of the guideline, which is perioperative management, is something which is pertinent to both non-functioning and functional adenomas, where we are getting them to surgery. And we know that besides prolactinomas, all other functioning adenomas will be surgically operated as well. And as we time and again stress upon the need of a multidisciplinary approach for these patients, that is important. And those of you who are endocrine fellows in training and attending this session, inshallah, we'll be having a pituitary adenoma multidisciplinary team meeting during Pakistan Endocrine Society's annual conference to be held in Karachi. And that will be something that will reflect and show how an MDT is working. So the components of MDT should include endocrinologists, neurosurgeons, radiation oncologists, are the main components, but there could be
And the
other,
radiologists as well.
and the radiologists as well, because they are the ones who will give us the delineations of the tumor. And through an MDT, we can ensure that we will be managing patients in an evidence-based manner, avoiding any harm to the patient, and then improving the outcome in manners which are appropriate for our resource adapted and low income status as well. And as we discussed in today's session, and Dr. Shahid, I'm really grateful to your excellent talk and your wonderful chapter as well. You have contributed so well for this guideline, that we need to be careful about some preoperative hormonal assessments, even if there is an NFPA, so non-functional pituitary adenoma, and other adenomas which are macroadenomas, where we know that there could be hormone deficiencies. And two hormones which are very important to be replaced before we subject a patient to surgery is thyroid hormone replacement and hydrocortisone replacement. And whenever you have two hormone deficiencies, you all must be aware from your medical school education that you replace steroids first and then you follow them with thyroid hormone replacement. And generally we will expect that these surgeries would be done in an elective manner. But there could be situations where there is an urgency or an emergency situation where you won't be having time to do everything in a manner that you are able to monitor those patients. But in a emergency situation, you know that at least you have to give them hydrocortisone and take them to surgery. That could be a situation where there is a pituitary apoplexy that is leading to compression effects, and where you will need to do a surgery in an urgent situation. So every patient will be difficult and different from another patient. The guidelines are there to give you an idea, but there could be patient who will not be falling into those situations that we have discussed in the guidelines. So those are general guidelines. In situations where you are stuck, an MDT is something which will help you. The multidisciplinary team will be there where experts from different specialties will discuss the patient and decide what is the best treatment option for this patient. And this is what I have to say. I don't know what else is required. So Dr. Vasu, over to you. Thank you very much.
Okay, thank you so much, Dr. Aisha and Professor Najmul Islam, and for sharing your valuable remarks and key take-home messages for all of us managing pituitary adenomas in clinical practice. So as we approach the close of our session, on behalf of Pakistan Endocrine Society, I would like to thank our speaker, Dr. Shahid Ahmed, for his wonderful presentation, and it was very impactful. And our esteemed panelists, Professor Najmul Islam, Dr. Aisha Sheikh, for their valuable remarks, and finally, all of our attendees for making this session so engaging and educational. So we hope this discussion has equipped them with the practical strategies and renewed clarity in managing pituitary adenomas perioperatively. So stay connected, stay evidence-based. Thank you so much for joining us. Allah Hafiz.
Thank you, Vasva. Thank you, Dr. Colonel Shahid, and thank you, Aisha.
Thank you, sir. Thank you, Dr. Aisha. Thank you.
Thank you.
Allah
Dr.
Hafiz.
Najam.
Thank you, Dr.
Thank you,
Dr.
Dr.
Vas.
Ahmed, and thank you, Vasfa, for an excellent moderation as always. And thank you, Anas, for your administrative support. Thank you, Atif Bhai,
Thank
Harun,
you.
for your administrative
Thank
support.
you.
Thank you very much.
Assalamu alaikum.
Allah Hafiz. Allah Hafiz.
Allah Hafiz. Thank you, everyone.